got
my McDonald's Diet Coke.
Did you say McDonald's?
I got McDonald's Diet Coke because I think they're Diet.
McDonald's is so iconic. I love McDonald's meal.
Right? Oh, this is the behind the scenes everyone wants, Chris. Like,
I love McDonald's. I can't even lie.
I almost texted you guys and was like, "Do not judge me. I will have a McDonald's Diet Coke." And I've already had a French fry, and it's 11 a.m. here.
Hello, y'all. We're live. How's everybody doing this morning?
I'm good. How are y'all?
So I got the Starbucks, and then Liz, you got the McDonald's.
My extra large McDonald's Diet Coke, you know. And
then Allegra, you got like the home coffee or?
My homemade coffee. I can't show y'all what the cup says. It's not PG, but yes, I have.
Wait, why do we have to be PG on here?
Okay, you're right. Should I show the cup? I'm scared.
Yes.
Okay, it says hydrate and masturbate. It was from a Liz was not expecting.
I was expecting the F-bomb, but here we go.
It was from this like vibrator company sent it to me.
Oh, here Chris is blushing.
I'm blushing.
Like on a live stream.
Here we are. You'll never know what you get. This may or may not be an exposure, and we're only 3 minutes in. So yes, welcome. We are so excited. This is what we live for. Hi, y'all. So good to see everyone. I'm going to do our quick intro so we can do fun stuff instead. But just a reminder, this is a live stream where this is not intended to replace therapy, to be therapy, and certainly the IOCDF or our live streams are not a crisis line. So if you're feeling unsafe or suicidal, please go to your local emergency room. Call 911, or nowadays you can call the crisis hotline at 988, which is amazing to have that throughout the US. We're just so excited. I don't know how many of y'all attended. I guess it was 2 weeks ago now, y'all, or 3?
Why does it feel like 7 months ago, but it was 2 weeks ago?
2 weeks ago, right? Yeah, I know.
So long ago.
That's crazy. It feels like forever. Maybe it's because all of our frantic texting in between and our it's like, no, that couldn't have been just 2 weeks ago. Like Allegra's been to the Hamptons in between, like life has happened. So here we are. So we had Allegra on, as y'all know, a couple weeks ago, and it just like really, I don't know how, I want to hear what y'all feel, because I think people want to hear this too, but like, I feel like it really ignited like a fire in me, if that's the right word, but just, it got like, I feel like our talk, maybe it wasn't just me, but it got me and the community, maybe I'm wrong, but like, just so excited that we're just talking about language and treatment and like what it means and what to expect, and that we're like dispelling myths. But what are y'all's thoughts? How do y'all feel? Because that's how I feel.
I'll let you go first, Allegra, but I definitely have thoughts.
Oh, I was going to say husband. I'll allow you to take the floor. I feel the same way for sure. I feel like there's so much change happening in the community, and I feel so passionate about helping people and helping people like discover new places in their healing. And I think that that's what these conversations are doing. So I left feeling really passionate and just honestly very grateful to be doing the work that I'm doing with clients. That's been a feeling that I've had. I mean, I always have it, but like a lot recently. And I think that this has been part of it.
Yeah, no, I what I was thinking about is, so I run 3 groups, but 2 weekly groups for people with OCD, and I played half of it 2 weeks ago, and then the second half actually this week. So the Wednesday group hasn't seen the second half yet, but last night, I played the second half. What I thought was so cool is just seeing the reaction. I know obviously we got reaction from other clinicians, and I think that clinicians focus so much on terminology and think clients care as much. What my clients in the group really seem to, and the clients in my group aren't just my clients, they're either from people here at the center, or we have people that see other therapists that aren't even affiliated with Gateway. And what I really got from all the people watching it is they just felt that the conversation was so inspiring, so hopeful. They weren't so stuck on language. They were more excited about the concepts. So they liked the concepts of like, through treatment comes learning. Through treatment comes understanding. You get closer to things you want. One of, I think, the most profound things somebody said in my group last night is they said, I don't think before treatment I ever knew myself. I don't think I even knew myself when I was a child, because there was always OCD involved. So treatment really got me reconnected with who I organically am for the first time, like authenticity. So I think what I just got from the live is just so many people in these groups felt inspired and motivated from the concept. So I was excited to do this part too. It seemed to help them so much.
Yeah, I feel like I want to caveat our talk today, because I think our last talk, I don't feel like it was like mind blowing. Like maybe I'm wrong, right? But I felt like it was just genuine, and it was just us speaking from our own personal experiences or the way we treat and work with our own patients. And it was just this kind of like genuine space. And so I want to just remind people, and some people on the live stream might be like, what is Liz even talking about right now? And so I'll kind of tell you, but like, it's really important that the three of us make sure everybody knows that like creating a safe space where we can all talk candidly is so important to us. And like, I know for me, that's just like a place where I don't want anyone to ever think something Liz says or Chris says or Allegra says, it's like a right or a wrong. It's an opinion. It's a thought. It's experience, right? It's experience as a clinician. It's experience personally. And I think it's really important, because the thing I want to say today is, as we hop into these concepts, like I want to be candid. Chris, Allegra, and I probably don't all agree 100% with everything each person says. And that's okay. Like that's actually like,
what?
Hold up, Liz.
What?
What?
I'm like, wait, what are we? No, I'm just kidding.
Yeah, what that you don't agree on?
hold on there. Like, no, but I want us to make sure that we're clear that like clinical interventions have room for personal interpretation, right?
Yeah.
And they have like, and I feel like the world, like we've gone so far of like, for example, if you do ERP, that means you're like traumatizing people through exposures. And I'm like, what? Like, how did this get from that? Like, I am so confused right now. And like, if you do this and versus like, actually, let's all just talk about what we've done personally for ourselves, what we do professionally, how it works, but also help the community understand the myths that exist. But really, like, I feel like our last talk, and this is my main point, and then I'll be quiet, is, well, y'all know I won't really be quiet.
I'm like, none of us
Liar. The goal is freedom. And guess what? Like, this is going to sound crazy coming out of I don't care how you get there. I care that you get there. You know, and I'm not, and like, I think sometimes we think, oh, because this is what we do, or right, it's a right or wrong. Like, no, it's not. It's like what works for you and what works for your journey. And we all have lived experiences with OCD, but they all look different. And our interventions look different, and the way we sought treatment and our levels of care. Mm-hmm. And that's okay. Like, I want to allow space for that, because I just want to pause for a second, because I feel like our community, we've gotten a little bit sometimes far away from allowing space for like differences of opinions, different journeys, but also just interpretations and things feeling black and white and it's right or wrong, versus like, no, like the goal is freedom. I don't, like, no matter what, that's the goal, but like, I don't care, like, what, you know, great, what'd you do, what worked, what didn't work, how can we learn from each other?
Yeah. Chris.
Yeah, no, I was going to say, very well said. All of us, I think if we all had a camera on us treating, there would be a lot of similarities. And I think that what I hope my clients trust me in is that I continue to educate myself in as many tools as I can. And when I'm sitting across from a client, if something isn't working, I try to adjust to something else. I think one of the things that people really resonated with our conversation from the previous was, you know, how treatment has evolved. And so, you know, one of my clinicians that runs the Tuesday group with me was talking about that. He said, you know, when I was getting OCD treatment for myself, it's different now the way that I do it. And so, you know, I think that's important, is that what we all came away from saying last time is that there's a lot of really good tools that your therapists are using. Some people are going to be very gung-ho about one modality. Other people are using more of a like evidence-based blend, as John Hirschfield calls it. And so I think the best thing to do is to find a specialist who eats, breathes, and sleeps this disorder. And if you're not getting better, or you're hitting roadblocks with your clinician, have those conversations. And if ultimately it's not working with the clinician, see if you can work with someone else. I think that's the biggest conversation, versus getting so caught up in, you know, I think some clinicians, not my clients, but some clinicians that watched our live got so caught up in modality versus hearing our overall message that we're really trying to share.
Yeah. And just this reminder, like that, so it's interesting, right? I always think about it like a journey to health. Like, none of us are one to say, like, here's what health means, because this is going to feel weird to y'all. But like, and I'm serious when I say this, but like, my McDonald's Diet Coke is like a part of my health. And y'all are going to be like, Diet Coke, like, how is that? But it truly is, like, it is self-care for me. I love a McDonald's Diet Coke, and right, that's my thing. And so, but like, no, right, no one's going to be like, well, that's wrong, or this. And so I think it's like, there's variance in everything, but also one thing I've been really bothered by, and then let's segue in, is that for some reason, ERP has, for some people, become this trigger word of like, ERP means and often that includes these like terrible things, or this right where a lot of us are like, how did that happen? And so I'm hopeful that today, and I'll let y'all take the lead, but like, I'm hopeful, I love it, Matt, that you want a McDonald's strawberry milkshake. It's just so frustrating. Their ice cream machine is like broken 50% of the time, right? Like, that's so annoying about McDonald's. Anyway,
wait, you're so right. I'm like, and it's like always the time that you want it. Like, I'm in line,
the most, yeah,
in flurry, I'm like ready to go,
yes.
And they're like, sorry, it's broken.
Ice cream machine's broken today. And you're like, no, you just didn't want to clean it. But that's fine. Like, it's here. We will all get forgiveness everywhere. Right. But what I want to talk about today, and this is kind of something I've been thinking a lot about since our last talk, you guys, is treatment that I did 20 years ago that worked for me is not the same way I would treat my patient today. And I think it's really important for us to unpack that a little bit. And because it's not mutually exclusive, like, it doesn't mean it didn't work. It actually did work for me. But now that we've learned so much more about ERP and values-based treatment and what it should look like, we've learned that you can get to the same outcomes without having to do some of those things that I did back then, because it was more like standard and it was 20 years ago and our understanding was very different. And so I would love to make sure we unpack that. But what, Chris and Allegra, what are y'all's things today that you want to make sure we unpack?
I think, yeah, I absolutely agree with you. Like, myths around ERP, and then just like treatment options in general. I feel like clients knowing that they have options, and knowing that, like, I feel like for so long I was hesitant to, like, not hesitant, I guess, to talk about, but like saying that mindfulness and cognitive therapy were the two most important parts of my own treatment. I feel like sometimes we hear like cognitive therapy is not good for OCD. So just like knowing that there are different tools that work for different people, and like talking about all of the options. And then, like you said, Liz, like really debunking myths of like, this should not look like this, right? Like, this ERP doesn't have to be this horribly traumatizing thing. Like, exposure can literally be changing your baby's diaper, just something that has to be done, you know?
Yeah, life, right?
One thing that I'll piggyback off what Allegra said is, as I was reflecting to get ready for this live, I was thinking like, okay, in my own care, because I think all of us have lived experience. So in my own treatment, what were sort of things that helped? And when I look at my treatment with Karen Pickett, she really focused on ERP. That was the main. And she kind of did ACT. I don't know if ACT was a thing back then, but very much ACT. Like, everything that we did, it never felt like I was doing an exposure to do an exposure. It was always like, this is the purpose. This is why you're doing it. This is how it reconnects with the things that matter to you. We're going to get you back into the life that you've always wanted. But throughout my journey, I think one of the things, like you said, Allegra, mindfulness was such a key. I got into martial arts right after my treatment.
Okay.
And my, what? I know I could beat people. That's what I'm saying is, like, I've done martial arts my whole life. Like, I may look innocent, but I could beat people up. So if y'all mess with me at the conference, pow, right? So I did martial arts, and my sensei was so focused on mindfulness. And I remember kind of talking to him about OCD. And then I found a lot of the teachings of mindfulness. And they always talk about, like, in the present moment, anxiety cannot live. And that always stuck with me, but with OCD. And one thing I've done with my clients since I've started treating is, when I have a client in the office just freaking out, it's like, let's get back to center. What's going on? How did we get to a point that you're having a panic attack in my office when we're literally just sitting here talking? I've always thought that OCD treatment has a missing cognitive component. I learned a lot from Barbara Van Oppen from USC. She does a lot more cognitive treatment. And when some of her clients would come to my support group, they would talk more about the cognitive component. And she and I are very close. And she kind of talked me through the cognitive components that she did. And I found that helpful. And then finally, I think when I was writing my thesis and learned about inhibitory learning, I was kind of moving away from the habituation model and getting more with my clients about processing exposures, learning, connecting the dots. What did you just take away from that? So I think as we go through our treatment journey as people with OCD and as clinicians, we learn about these different kind of life-changing things. Now, lastly, what I'll say about it is some of those things don't resonate with my clients. So I'm not going to push those concepts if that's not the thing that clicks. Sometimes it's something else. So I think that's what we always have to do as clinicians is like continue to expand our toolbox, try different things with clients. And I'll have 5 clients back to back that different concepts really, really work for them. And awesome, let's do that. Whatever's working for them to get to freedom. Yeah.
I feel like the word that just popped into my mind was and I feel like that's such an important word here. Like I've heard people say, like for me, the post I put up this morning on my Instagram was all about acceptance. That was like truly such an important component of my treatment, acceptance of the presence, not the content of thoughts. And sometimes I'll hear clinicians say like, but what if we could do more than merely accept those thoughts? Okay, but what if we could accept the presence of those thoughts and get closer to trust and clarity and certainty? Like it doesn't just have to be this or that. What if we could use this tool and add in that tool? And I think sometimes we do get so stuck on like, it has to just be this. What if we can do exposure and add in some cognitive work? What if we can do, exposure and add in mindfulness? What if we can do ICBT and move toward behavioral change and do exposure, right? Like it doesn't have to just be, what if we do this? What if we do this and this in service of what works for the client? Like you said, Chris.
Yeah. So we did this talk at the conference this year that Chris couldn't attend. He was supposed to be on it, Michelle Massey and myself and Chris. And it was about treating the whole client, not like the whole client, not just a piece of them. Right. And it's interesting because I found that early on in my training, I was so OCD focused that when a patient would come in and they'd gone through a breakup and they were like, it was like, ooh, I don't think I should be talking about that. I think we should.
What do I do?
Like, what do I do? I don't know how to touch that, right? Where now with my trainees, I'm like, okay, so you spent a whole session talking about their boyfriend, and they're like, but was that wrong? And I'm like, no, that was right, because like that's what your client needed in that moment. Now, if they're doing it every single week as a way to avoid treatment, yeah, we want to talk about avoidance. But the reality is that it is our job as clinicians to meet you where you are and to figure out what you need. When Ethan and I first started doing advocacy 5 million years ago, Ethan used to talk a lot about how DBT was life-changing for him. And I remember at first being like, oh, Ethan, like we kind of want to be careful because we don't really want to send the message to the OCD group that DBT was what helped your OCD. And he's like, but Liz, without DBT, I couldn't have done ERP. I couldn't have done exposures. Like DBT was so life-changing for him and what he needed at that moment. And it was so powerful for him and I to be able to like talk through that, but to share it on a public platform of like, yeah, like each person's journey looks different. And isn't that beautiful? And isn't that amazing? Because it still got us to places of freedom and relief. Even if it'd be kind of boring if like all we did was the same exact therapy with every client every day, right? We'd all kind of be like, I don't want to do this work. I'm so bored, right? We love being able to like, what do you mean? Who are you? What are you presenting with? And sometimes you start with ERP and you pivot, or you start with something, right? And like, that's the journey and the beauty of working with a patient. And so I do want to caveat and start today with, I loved Allegra's goal of like treatment options and the variation in modalities are something we should always be talking about. There is not a one size fits all, because guess what? Like my dad always says, like they threw away the mold when they made you, right? But like there is no person that's the same, right? Like we are all our own unique people, and we show up with our own symptoms, our own presentations, our own diagnosis. And Chris and I have talked a lot about this in the past when we've talked about comorbidities and how you figure out what to treat first and what that looks like. But if you're showing up with PTSD, you shouldn't be doing ERP, right? We should be doing PTSD effective treatment, and then maybe we add in ERP for OCD. But, we really want to figure out, how do we treat you, not how do we just like get rigid in what we do. And we're teaching you flexibility.
Yeah, as you're saying it, I mean, 2 thoughts that came to my mind. I remember a talk we did, Liz, with my family. And when I was in high school, my OCD got really bad. I was very, very explosive. I was breaking things. I was throwing things. I was getting fights in school. I was like very just dysregulated. Yeah. And I remember you saying like, if you were my clinician, you would have gotten me to get DBT to like emotionally regulate. That wasn't an option, I think, back then, or it was an option, just nobody ever talked to me about it. But I think about that all the time, and I'm like, yeah, no, that would have been really helpful. The second thought that I have is like when I work with body dysmorphic disorder, where I work, we have a lot of access to different things. We have malls around us and parks. And in the IOP that I run, a lot of clients are extreme and they haven't left their home in years. And so part of the treatment, usually starting the second week, is we walk outside, we go to a Starbucks, and sometimes that's like the first time they're ever out. And a recent client of mine, the behavioral component wasn't working as well. Typically for my clients with BDD, it works extremely well because they're just excited to get back out of their house and like go to the mall. I think I'm funny, so we're laughing together and talking
You're
together.
Hilarious.
At least they're laughing to make me feel better, right? So we're just like talking, we're vibing, and they're just like, Chris, I feel so normal, and all these concerns I've always had like have just faded because none of it's coming true. But a client recently, just the behavioral part wasn't clicking because he was out there and in his mind he was kind of reversing everything we're doing. And so we pulled it back. We stayed in the office more. We focused a lot more on like where the thoughts came from, the cognitive part, the restructuring of the thoughts, like digging at core fears. And so it just comes back to like, even as somebody who practices ERP, there's times where I'm like, whoa, we need to shift over here or shift over there. So I think that's what, nobody's saying let's abandon like gold standard frontline treatments. Let's just make sure that we're not throwing things away. But as we add new things, treatment's going to change and adjust from where it started. It has to have. Nothing doesn't expand and grow.
Allegra, one of the things, I attended your webinar this weekend, and one of the things that you talked about that I really love, that I'd love to hear you talk more about, is just like, I was like, yes. And like, I couldn't, get on and say that while you're talking. But when you were talking about psychoeducation versus reassurance and how critical that like important beginning stages of treatment are, right? Like when I lay out a treatment map for trainees, I'm like, listen, like what's the main 3 things in treatment? And half the time they're like, I don't know, Liz. And I'm like, psychoed, intervention, and termination. But like, we need to think about like, okay, in the psychoed, we're doing readiness to get you ready for that intervention. And I'd love for you to talk a little bit about that, just about how some clinicians don't want to even do psychoed because they think it's reassurance, or like they're not even providing education, and how horrible it could be and how much it can get people stuck.
So yeah, what I said was like, basically with regardless of therapeutic modality, psychoeducation has to be the first thing that you do. It just has to be. And I'll give you 2 examples. I actually talked about this for the first time on my webinar, but I saw an OCD therapist when I was like maybe 22 for like 4 sessions or so. And from what I remember, there wasn't much psychoeducation. It was kind of like, you're going to go sit at the playground, and like would pull up like documentaries as exposure and just like stand behind me as I'm watching them in session. And I didn't know why I was doing the things that I was doing. And I dropped out of treatment for other reasons as well. But like, it was so awful for me to like not have that kind of psychoeducation, to not know why I was doing ERP, how it could be effective, what OCD really even is. And so when I went to my second clinician, who I will fully say who it is, Shiva at, I don't know the name. It's like CAOCD or something. Shiva Rajai, brilliant clinician, changed my life, saved my life. And we had I got a psychoeducation manual. In that whole manual was articles about POCD versus pedophilia, how they're 2 very different things. I learned about ERP and how that can be effective, what cognitive therapy can do, the rewiring of the brain, why thought suppression doesn't work. All of that allowed me to do the treatment work. If I didn't have that, I never would have stayed in treatment. And it wasn't reassurance. I genuinely didn't know that we could have thoughts that weren't true. I genuinely didn't know that I knew that there's a difference between pedophilia, but I didn't know wow, the ego dystonic versus ego syntonic. Our clients need that language. It becomes compulsive when a client is asking over and over and over and over about something that's already been taught. But I think so often as clinicians, we think everything is reassurance. And we also have to remember that people need reassurance sometimes outside of OCD, right? Sometimes we just need reassurance that somebody loves us, or that, they like our new haircut, or whatever it might be. So I think sometimes Chris is like, I don't like your haircut.
I wasn't thinking that at all. I was like, we need to match the hairs. We need to dye our hair the same color. That's what I was thinking.
Please. So I think sometimes we get super rigid about this is reassurance. No, it's education, especially when it's the first time you're doing that with a client. And that is mandatory. No treatment should not have psychoeducation. I hope that made sense.
Absolutely. No, that's like, and you guys, I can't even tell you how many patients I've had who come to me and they've come from a decent provider, a good provider, people I even trust or that I know. And I'm like, hey, like, what am I going to do different? And they will say to me, listen, we started with ERP sessions 1 and 2, and I feel like I didn't know why I was doing that work. And I'm always like, what? And so it literally even like John Grayson talks about how sometimes he does psychoed for 6 to 8 months. Like, your patients, no matter what intervention you're doing, you should be at a place with your patients where they are actually kind of convincing you of what they need to do next because they understand it so much versus I'm trying to tell you to do it, right? Like, you have to want that more than I want it, right? But you have to understand it. Yeah, I think someone wrote that, day one, like at the very beginning, their provider was having them watch violent movies. It's like, yeah, like that would make no sense. And that would be harmful. And that would just reinforce your fears. And you would end up, more triggered and not able to just habituate or to be able to, learn through it because you wouldn't understand why you're doing it and the skills you need to do. And I also think, you guys, I think this is why mental compulsions and rituals got such a bad rap for so long. We have so many patients that when they first come here, it's like, oh, well, I'm different because I have mental compulsions. And I'm like, why are you different? Like, tell me about that. Like, no, like, it's no different. Like, all of us with OCD often have mental compulsions. But there was this, for a long time, there was this kind of like belief or understanding that like, oh, you're different or it's treated different or you can't manage, like, mental compulsions, like, can't be controlled. And it was like, wait, what? And so again, how can we make sure and that's all things that should be covered in psychoed. In the psychoed stage, we should be helping you identify all the compulsions you do. You should be able to say, even if you're not in the intervention stage, you should be able to come into a session and be like, okay, Liz, like, I'm struggling with this, but I know why I am. And I know what I'm doing that's promoting it. And let me tell you, but I'm struggling to not do it. And that's when I'm like, you're ready to dive into work, right? Because you already know, like, I know I shouldn't be doing it. And I know all these different things are making something scary for me.
Yeah. And even like values-based work, which I know, Chris, that you love and like who you are outside of OCD. Before we even got into like ERP, we did like 6 months and 5 years of where do I want to be? So every time I had the urge to perform a compulsion or to do something that wasn't helpful, I thought about like, in 6 months, I want to, I don't know, go to Paris. I don't know what my 6 months was. I was like, I just want to survive, honey. Okay.
Right. I just want to get through this week.
Yeah, literally. I just want to get through the next hour. And then it was like 5 years, family, kids, a home. And like that work is so important, that like motivation and having clients understand their why and why they're doing these things. And like, I think all of us do these things. And sometimes that gets maybe like people aren't aware that like there are all of these different components that can be so important and helpful.
Yeah.
Well, what I'm loving about this, go on.
I was just going to coin really quick, like, not coin, I'm not coining it. Jeff Bell really coined the topic of like that greater good, right? And we talk about that so much, is that like, for a lot of us, like I have my patients, I was trying to look for it in my paperwork, but do this quick worksheet of like your 6-month goals, your 5-month goals, because guess what? In the psychoed phase, before we start intervention, I need to have reasons that life can be or will be louder than OCD. But if your goal is like, well, I just need to fight my OCD, guess what? Treatment's only going to stick so much versus it's going to stick a lot more if it allows you to get back to life. And then you want to keep living life, and life is louder than OCD. Chris?
Yeah, no, I was going to say, and I think you were there, Allegra, when you and I were in Colorado right before the whole world ended for the pandemic. Dr. Stephen Phillipson was speaking at OCD Game Changers. And I remember like one of the things he talked about, I've always been interested in the brain, but he talked about the amygdala in the brain and how it's overactive for people with OCD. And when you're in that sort of like fight or flight and you're in that world of just like panic, your brain can kind of make stuff up. So he was like giving examples, like if you're out in the forest late at night and you hear cracks in the grass, like your brain's making up like this like bear coming after you. And so one thing that kind of influenced my psychoed with my clients, I've always liked to talk a little bit about the brain. And if a client's more interested in the science, I'll push more on it. But the amygdala being the fear center of the brain, very sensitive for us, sends big old signals to our frontal cortex and says, danger, danger, right? And I use like what Stephen Phillipson taught me, 3-4 years ago of like your brain, when it's in that state, can make things big. It can make things scary. It can kind of like blow things up and sort of get out of reality and kind of create this like bigger story. I see a lot of people in ICBT kind of call it like like your imagination, right? Like, you know, your imagination. And so that's where I first heard, from Stephen Phillipson. But I remember leaving that. And now when I do psychoed with my clients, I'm like, the reason that your brain can go straight to like, you ran over a whole family with your car is because you're already in this heightened state because you're driving, that's your trigger. And then any little bump you hear, any little kind of like brake thing that you do and you kind of rock your car, like now your brain is already in that flight state. And so I think that's the big thing is like clients come in and have done OCD like behaviors and thoughts for so long that then they get to a point that becomes their normal way of thinking. And if us as clinicians don't start off treatment saying, let's kind of teach you what's going on in your brain so that you can then understand why it's not helping you and why we need to get out of there, then people are more willing to do it. What I wanted to ask y'all about, two things, but the first one is, I know for a lot of times when people come to our clinic, because we have higher levels of care, what I see is that there isn't a focus on the mental part of OCD, the mental compulsions, the way that obsessions start, the way that then people take them and turn them to compulsions. I always talk to clients about confirmation bias, right? Like your brain is always going to come up with new reasons why the OCD is right. So what are some things that y'all do in treatment to really help clients? Because I would argue that everybody has a mental component to OCD, even if it's behavioral. And that's something that I recognized probably in 2015 when I started IOPs. I'm like, so many people are not treating the mental part. So what are some of the things that y'all do to make sure clients really get what to do with their thoughts, with intrusions, with beliefs? Like, what do you all kind of focus on?
Liz, do you want to go or do you want me to go?
Go ahead. Yeah.
So mindfulness, again, and for me, mindfulness, I like to think of it as acceptance. So teaching my clients how to coexist with unwanted thoughts and images without judgment. Because again, even if you recognize that OCD is lying to you, like I still think people with OCD, especially because how the OCD brain is wired, like we get more of those intrusions than people without OCD. So I do a lot of mindfulness skills training, how we can observe and let it exist and redirect our attention back to the present moment. And then I spend a whole session or two going over like an in-depth document about mental compulsions. I have them come back with homework that like identifies mental compulsions that they've performed during the week so that they're able to like understand that. And then we talk about how to stop mental compulsions, because that's very different than trying to suppress an unwanted thought. The mental compulsion is active. You are choosing to do it, even if you've jumped into it habitually. And I feel like I'm like a walking ad for the OCD Center of Los Angeles, but like that's where I was trained. And I know
that's where my treatment was. So we're like, yeah, I'm on Laura Yoakum. We better get 5%.
No, literally, I'm like, Laura, honey, I'm doing the Lord's work for you. No, Laura was my supervisor, and she gave like a whole, I think it was called like mental compulsions glossary. And like, that's what I would give to all of my clients. And that's where I was treated when I got my own OCD treatment. So like a lot of comprehensive stuff that like, I'm a big fan of manuals. I like giving my clients something that they can like read. And so I would say like mindfulness work, knowing what mental compulsions are, and then helping a client stop actively engaging. That was a long answer.
Yeah, no, I think y'all hit all the nails on the head, and like that's exactly the right route. The one thing I like to do a lot of as well is really help people see that whether you have OCD or not, you do mental compulsions, right? You have an awkward interaction with somebody, with a family member, and then you're ruminating about it, you're thinking about it, and what does that do? Well, it makes it stay on your mind, it gives it more power, right? And until you hear from that friend again, you're like still anxious about it, right? Or you can't move on, versus can you choose to not actually like engage with that thought and be like, like, okay, yeah, there's that thought, right? Mindfulness, right? Kind of like, it's there, I'm going to coexist with it and move on. And then, wow, that interaction has less power in it, right? And so I want people to see too that like, it's not just for OCD, it's actually for all of us all the time, right? It's, you know, when your boss sends you an email saying, come see me, or when this, right? All these things.
Literally, I'm like,
you're like, I can't tolerate it, you know, which by the way, I want to bookmark that because I have a lot of thoughts on that. So we'll talk about that a little bit later because this has been my spiel this week in group. But anyway, for me, I think one of the big things is it's interesting because I think I, throughout treatment, have gotten, not treatment, but as a treatment provider, have gotten a little bit upset when people think like rumination disruption is the treatment for rumination. And I'm always a little bit like, ugh. So my belief, right, you guys, is that rumination disruption is an incredible tool during treatment, right? To kind of help you move through and to help you move on and to help pull you out when you're in that active rumination. But the long-term treatment is that you address what's at the core that's causing you to ruminate, right?
Amen.
Like we do not want you to have to spend your life trying to disrupt rumination. And I know I did that for years of my life, right? I would literally do serial sevens where you start at like 1,072 and subtract by sevens in my head for like hours. Just
That's too much math.
Well,
Too much math.
Like I never,
it's better
I'm like,
than
if my
ruminating.
calculator can't do all that math, I'm done.
It's better than ruminating, right? But like I would literally, and I would do that to be able to get up in the morning and get in my shower and like get out for the day. And yes, that was a useful tool to like while I first started treatment, just to keep me moving so that I wasn't just stuck in my head, because sometimes we need those tools. But that, my gosh, you saw Chris's face. What a terrible idea if that was long-term treatment. Like, oh yeah, Liz, you just have to do that forever to be able to move forward. It's like, no, like the long-term goal is that we actually get at what even causes you to ruminate, right? And so I want to be really clear about that, because I think a lot of times people with mental compulsions, or when we're engaging in mental compulsions, we think that like, oh, we don't have a choice and we'll never have a choice. Like we're always going to have these really loud, exhausting, draining, physically and mentally, like, you know, totally torturous compulsions that we're always having to fight against. And it's like, no, treatment should actually get you to a place where you no longer have those triggers. You no longer have those intrusive thoughts. You no longer get pulled into mental rumination. Like you're not having to engage with it all day.
I agree. Chris, go.
Oh, go, Allegra.
No, go.
What I was going to say is one thing that I always think about is the difference between somebody with OCD and rumination is we will continue to fixate on something despite not getting new information. And that's what's so different. And it's funny because like my whole life is like OCD, right? But then when I hang out with all my friends that don't have OCD, I'll ask them questions. And just like you were saying, Liz, is like, I'll ask them, like say you have a presentation coming up and you're really anxious, or an email from your boss. What they'll basically do is say, yes, when I get that email from my boss, I'm like, oh crap, freak out a little bit, but then there's no new information. So they're basically like, well, I'm either effed or I'm going to go in there and I'm getting a raise. So we'll see what happens. Right. But for us is like, we will continue to ruminate and ruminate and ruminate. And I always go back to what is rumination. There is a rumination disorder. It's mainly for children. It's an eating and feeding disorder where they chew up food, spit it out and re-chew it. Birds do that, right? That's what we are figuratively doing with the thought. The thought doesn't have any new information. So if I'm fixating on something that's happening in a week, if I'm ruminating the whole entire week, or vice versa, if I just had an interaction with somebody and then I ruminate for a week after, there's no new information or data coming. So I'm basically opening up cold cases in my brain, reading the information, not getting anything new, shutting it, and then picking it back up and picking it back up. And so just like you were saying, Liz, is like, that's why I like to focus on clients' core fears, is like, what is driving the rumination? There is something that you're trying to fix, solve, get rid of, etc. And because of that, it's causing you to just keep spinning on the same thought. And so the treatment is really saying, look, I'm not getting any new information. This rumination isn't helping. In fact, I'm just kind of collecting crappy data and putting it together and creating something big and scary. So I do think that all clinicians and everybody watching, like in your treatment, there should be a big focus on mental compulsions. Because I think going back to what both you were saying is there's a difference between having an obsession that pops up accompanied by those stress hormones and spending 6 hours in your head. It's now turned into a compulsion and you're actively engaging, even if it doesn't feel active. And that's now 6 hours of compulsions, which is the same as washing your hands for 6 hours.
Yeah. And I think what you said, Liz, is so important and so profound. And like, Chris, you like adding to that is like, it's not enough to just say like, stop ruminating. It's going to be really hard to stop ruminating if you're not understanding why you're ruminating in the first place. And that's where like psychoeducation and the cognitive really helpful in my treatment. Like I was going to ruminate about, let's say, groaner responses until I had that psychoeducation of your body can respond to what is sexual in nature, whether you desire it or not. Like we really had to break down OCD so that I wasn't like engaging. It wasn't enough to just say, stop ruminating. Like, I'm not going to fucking stop ruminating if I don't know like why I'm buying into this in the first place. And that's where some like psychoed, metacognitive therapy, even ICBT, I think focuses on like how we reason our way into obsessions. That's where that can be helpful. So it's like, not only am I stopping this rumination, but I know why I was doing it in the first place. Totally. That's like profound, Liz.
So profound, right? And you guys, like, I find this so much, I know for myself, and like when I also had sexual orientation OCD, when somebody was like, yeah, it's normal whether like no matter like it's normal to think all sexes are beautiful, and it's normal to have physiological arousal and to learn about arousal and symptoms and gender fluidity, like the gender man, like all these things that you're like, oh my gosh. I like, right, have y'all used that worksheet?
No, I haven't.
Oh yeah, it's so amazing. But it's an incredible worksheet about gender fluidity and helping
I love that.
like, yeah, like life is also a spectrum, and OCD wants your thoughts to be black or white. I 100% know or not, right? And it's like, that's why we get stuck, right? Like, I want to know for sure this is or isn't going to happen. I want to know for sure my mom's going to be safe. Well, like, okay, like, and can we have room for variation and understand that that's just like actually a part of life and is healthy? Because again, if you go into treatment saying, okay, I want to get OCD treatment for pedophilia OCD, and I want to never have a response again when I see a child or that, right? Like those goals may not be realistic. Like instead, how about we help you understand responses that are normal, not normal, that happen, and we're not putting the weight on them. And then actually that goal might be realistic, that you might be able to get rid of some of those reactions because again, you're not hyper focusing on them. But it's really that education is so critical. Like we have to have really good education. And so next I want us to we need to hop into some treatment stuff. And so I want to kind of go there just because I want us to talk a little bit about, I want to talk about a million things, and we only have 20 minutes. So y'all
we need a part 3.
We need a part 10. Like we've got so much of this. But the one thing I think that I've been struggling with a lot is this belief that ERP means accepting uncertainty forever. And I know for me, you guys, like, first of all, I would not be doing treatment if I was telling people like, oh yeah, your worst fears could be true and you have to be okay with them forever. Like, that's awful. Like we talked a little bit in part 1 about the goal of ERP is to get you clarity. And yes, sometimes you have to live through some anxiety in between, right, to get there. So I don't want to pretend like, yes, if we could all just say, okay, I'm going to give you clarity and it's going to happen and tomorrow you have it. Like, yeah, I'd love to do that, right? We can't do it. So yes, there's a path to get there. But can we talk a little bit about maybe like some of the things you hear that like you feel like people think, like one thing I hear a lot lately that I'm fighting super hard against is this belief that if I have OCD, that means I just have to struggle forever. And this kind of like assumption that having OCD means we're never going to have freedom. And I will tell y'all, when people used to talk about freedom when I was in my struggles, like they're full of shit, like good for them. Like I will never get there. Right. And so I want to caveat it that like, if you're skeptical about that, that's okay. Like that's expected when you're in the middle of treatment or before you've gotten through treatment. Like, of course you're not going to believe it because you don't feel it right now. But I want to be really clear that the goal of treatment is not that you learn how to do values-based stuff and you accept that you'll have to struggle along the whole time with it. The goal of treatment is that you can just go do values-based stuff, and that OCD and anxiety doesn't play a role in your life, that it's quiet, it's not there, it's not loud. But I want to hear some of y'all's thoughts around things that you feel like you hear that are misconceptions or that you want to break down or that are important to re-clarify.
I feel like it reminds me of a little bit of like, and bear with me because this is not going to make sense, but like palliative care, like sometimes with like eating disorders, like there's a clinic that I really love in Colorado, and like sometimes a client will be on palliative care. I think that's what it's called, when it's like you make them most comfortable as essentially like they're dying. That's what palliative care is, correct? Mm-hmm. Okay. So like I think that's what people think of when like living with OCD. Like I just have to get really comfortable with like this being shitty forever. I just need to like manage this forever. And I want to say that like, you know, I think that there is like a spectrum, like some eating disorder cases are extremely severe. I'm not saying that you can't recover whatsoever. Like there genuinely are really severe cases, but I think that is like the like OCD is chronic and there's no cure and you're going to have to manage this forever. Like that I think does feel very defeating. And it feels like, okay, I guess the goal of treatment is to just get more comfortable living with all this like shitty discomfort. Instead of like, no, you can gain freedom from OCD in the same way that like I'm recovered from anorexia. Like I eat whatever the fuck I want. Like I live my best. I love McDonald's. I live my best life. Like that's possible with OCD too. It doesn't have to just be like, I'm going to have to just manage being terrified of food forever.
And it doesn't mean treatment's always linear, right? Like, I think
Oh
that's
my
the important
God, of
piece is like,
course.
so many times we think like, okay, so then it should have been like this. It's not. It's like, no, like, you know, Ethan talks a lot, and Chris, we've all talked about how for some of us too, like, you get over OCD and then it's like, wait, now I have to rebuild my life. Like, I don't even know what that's like, because OCD has been the focus for the last 15, 20 years, you know? And so I love it. Okay, Chris, sorry. But yes, I'm like, yes to all of that.
What I was just going to add is, you know, I was thinking, I see Grace M's comment at 12:35 about the self-compassion workbook written by Kim. And what I want to do first is like validate, because I do think the reason that there's a lot of clinicians, because mainly I hear it from clinicians in our field, that are kind of uncomfortable with the way that ERP is rolled out. So you're talking, Liz, about, you know, accepting worst case for the rest of your life. I don't know how you feel. I mean, I would categorize us as like a younger generation of clinicians. I know that when I first started treatment, I felt like there were certain things we just could not do. And as I started doing treatment, I was like, this isn't working for me. Like having a client come in the session and us starting exposures day 2, never talking about psychoed, I was like, that's not how I want to be a clinician. I was very fortunate that I got a lot of room to grow as a clinician. I didn't have a stifling supervisor, and I was, you know, going to trainings and learning all these things. So I totally understand when there's clinicians out there, and I've seen it from clinicians with lived experience. I was rewatching with my clients in my group. I'm not going to say her last name because I'll butcher it, but I think her, Allegra, you know who she is. It's Katie, who does like the ICBT trainings with Bronwyn.
Oh, Katie Moret, I think is her last name.
Thank you. I didn't want to butcher her last name.
Yeah, she's
but, you know,
sweet.
she made a really good point. She's like, in my treatment, my therapist was constantly having me accept that I was this bad person. And I'm like, no wonder people like that don't like ERP, right? Like, I do feel that there was this push. And so I don't know if it's because of my lived experience or what. And I'm like, this doesn't feel right. So one of the things that I've been trying to do, and I know Liz and I have been trying to do it on these lives, and we did it with John Hirschfield, and we're going to do a live with him later this month, is we've tried to present, and I think you've been doing it amazing, Allegra, and why we were so excited to have you on this stream is like, we're trying to present like, this is what ERP looks like now. Here's other treatment modalities that are fused in. Some people don't want to fuse it in. Like, there's all these different components. And so going back to the acceptance component you talked about, Allegra, and I would love to get your follow-up on this, because I think that's one of, going back to what you're saying, Liz, like one of the biggest misconceptions. You and I did, Liz, we did this talk last year at the online conference that was heavily attended, where we were literally shouting through the screen, your treatment should not be accepting your worst case scenario. You should not walk into your treatment provider and your goal is to say, I'm afraid that I'm going to be a murderer. And your provider should not say, we are going to learn to accept and be happy that you could be a murderer one day. That should not be what treatment looks like. And we shouted that out. And I hope people still resonate with that. But if you could go back to expanding on acceptance, Allegra, and I think it's because people really don't understand it. And I think I understand what acceptance means just coming from my mindfulness background. But what I find a lot is like, acceptance to me is acknowledgement, right? If I'm at the store and I walk by canisters of bug spray and my brain goes straight to like, it's leaking on you, you're having cancer, I'm not saying, I have cancer, I have to become happy and accept I have cancer. That's not going to work for me. But what works for me instead is saying like, I acknowledge that I just had a thought about that. And I'm going to acknowledge that I'm not going to let that thought influence me in any way. I'm going to continue to shop as I was shopping. And I'm going to acknowledge that that thought just came up. To me, that's what acceptance looked like. So when I was at family and I was having groaner responses and all of the sensations, right, around family members. By the way, I always laugh, and this is how stupid OCD is, because it was around female family members, and I'm gay. So it doesn't even make sense.
Honey, I'm fucking gay, okay?
Yeah, but it was more about just like the presence of the thought bugged me. Like, why am I having this thought? And I freak out. But that's what helped me with acceptance, and why those thoughts faded is because I would say, you know what? I'm going to my family's house. I already know that these thoughts are going to come up. I accept that the presence is going to be there, but I get to decide what I do with it. And I'm not going to do a damn thing. I'm going to go eat some good Greek food. I'm going to smash my whole family and beat them in any board game we play because I'm the greatest. I'm going to have a good time. Like, that's what I'm going to do. And so the thoughts didn't influence me or impact me. But Allegra, can you expand on acceptance? Because I think people sometimes, going back to your question, Liz, that's a big part people don't understand.
Yeah, that is exactly what I had to do, because like I didn't, like, my onset of OCD was really sudden and severe, and it was literally like the same thought, or like fuck a kid, sex, like all day long, like image. It wasn't just like a what if that I was buying into. It was like a lot of unwanted thoughts and images and sensations. And my idea of recovery was those going away forever. Like I remember it was when I was about to graduate from undergrad, I was like sobbing and shaking in my therapist's office. Like, I just want this one day, this one graduation to be void of these thoughts. Like, can I just fucking have that? And she looked at me and was very like blunt and straight up and said, like, no. And you've got to accept that. Like, you just can't. And you really have to let that be okay. And it sounds blunt and it sounds like harsh, but that like snapped me out of it. And I went to my graduation full well knowing that I was going to have images and thoughts arise. And I changed how I was reacting to them, and how I was responding to them made me struggle more, trying to get rid of them, suppressing them, saying, please don't come, please don't come. Like, that is a recipe for having 8 million. I'm trying to like hide my nail that's like broken. I'm like, that's a recipe for having like more of the very thought that
you more be louder. Yeah.
Yeah. So that's what acceptance meant for me. It was like, just I was not accepting the content. I was not accepting that I would be struggling forever. I was ultimately being super, super mindful. And like, I just have to live with a brain where like I have 95% less unwanted thoughts, but I still get intrusive thoughts every day. And like, that is my brain. I don't know if it's going to be that way forever, but like I implement acceptance every single day.
Yeah. It's so, I love this, you guys, just because I think, again, language is so important, but also can be so weird. Like, so I'll give the example, but I remember when people first were talking about like acceptance and mindfulness for OCD, and I was like, that's a pile of shit. Like, none of us can do pile of shit. You know, like I was like, who can do mindfulness when you have OCD? Like, that sounds awful. But then the more I've done treatment, I'm like, oh, ERP actually for me is also acceptance and mindfulness. So I'll give an example, but like for me, when this happened like a year ago, but when I had a super strong sexual intrusive thought around my kids, like ERP, what the exposure was the thought that already came, right? Like, it already happened. Like, I couldn't do anything about it, but I had to do response prevention, which is like, I couldn't try to figure out, why am I having this thought? What does this mean? Right? Because the more I try to solve it, the more I get stuck. Or if I tried to do like Allegra said, where I'm like, I don't want to think about that thought. Like, I just need to go have a good day. Guess what? That thought's going to be super loud and keep coming up and be super distressing. And so the way to move through it with, you know, which ERP acceptance, whatever you want to call it, is to be able to be like, like, that's a shitty thought. And like, nothing I'm going to do about it. I'm going to move on, like keep going forward anyways. Right. We allow space for these uncomfortable thoughts versus we react to them or we try to push them down, right? Because the more you try to get rid of them, the louder they are. Where actually, when you just kind of allow space and you don't act as if you're scared and you do what opposite of what Chris was talking about earlier, where like your mind's telling you danger and instead you're kind of like, like, I know about that fire drill we're having today. Like, that's a false alarm. That's not real, right? We can start to respond differently. And so I really want us to talk a little bit about the goals of what I will call ERP, because that's treatment for me and how I understand treatment. For some people, they call it something else, right? But like the goals of treatment, because I think it's more important for us to say, what is the goal of OCD treatment versus what's the goal of ERP, of ACT, of ICBT, right? It's like, what's the goal of treatment? And so can y'all both talk about like where you're at today and like what treatment got you to, so that people can understand what you should be shooting for and what the goal of treatment should be?
Chris, take it away.
Yeah, what I think about the goal is supposed to be treatment. If I have to like sum it up, I always tell people that your decision should be based out of you. You should be able to wake up each day and decide what you're going to do, and OCD should not have an influence. To go a little bit deeper than that, one of the things I always feel is that part of the treatment and recovery is getting to know who you are despite having OCD. There was a comment, if we could throw it up real quick, that Allegra and I really like, from our good friend Erica McCoy at 1246. A lot of us have different disorders and different things. I have, an autoimmune disease. I have, obstructive sleep apnea, body dysmorphia. Like, I have all these different things, right? And so I think for me, like my early 20s going through treatment was sort of getting all of that stuff handled. And then, like you were saying earlier, Liz, what Ethan was saying, I was then confused. I was now like 24 thinking, who am I? I'm so lost. I'm so confused. And so what treatment allowed me to do is move aside all of that, no longer being controlled by the OCD, BDD, I had major depressive disorder, autoimmune, like all that stuff, right? And then it was sort of like, who am I? And so I think that was one of the good things that came out of treatment is I think when other people were still lost in their early mid-20s, right? I got to self-discover. And I was like, well, I haven't known who the hell I am for so long. Let me kind of figure that out. So what treatment did for me now as a person is I feel like very confident in who I am. I really know myself. I really trust myself. I feel good about the things that I choose to do and the choices that I make. And I have a solid understanding. And I've spent my life kind of dedicated to give back to this community because I'm so passionate. I always say, I don't know if this will happen in my lifetime, but I always say, like, I want somebody to get symptoms of OCD and in that same month be able to get diagnosed and get proper treatment. And so that's why I do what I do. So freedom is a good word. You were saying it earlier, Liz. Like, I feel free. Now, does that mean my life is like perfect and I don't have loss and breakups and I don't have sadness and I don't hate traffic and taxes? Of course, all those things come up, but there's like OCD and related disorders isn't controlling my life. And I think that that's where we should get to. We talked a lot about trust on our first stream. And I think that was so important for me, is to finally get to a point where I'm like, I trust myself, but even bigger, like I know myself and I'm good with myself and good with my support system. So that's where people should be getting with treatment. If they're not getting there, there has to be some adjustments, because that's what myself, you know, these two lovely ladies and other people that do this work, that's where we've gotten.
And so, Chris, can you share specifically what treatment got you there?
Yeah. So looking back at my treatment, it was very exposure and response prevention based. I got treatment at OCD Center of LA under Karen Pickett. One thing, though, that I felt very different that I didn't understand as a client that I understand now is Karen always took a much more like ACT, acceptance and commitment approach, incorporated mindfulness, incorporated values. She did really good at explaining to me like why I was having harm thoughts. So she really went there. She did do cognitive stuff, maybe not as much as like I do or the field does now, but she really did that. And so when I look at my exposures were never just doing these behaviors for no reason, you know. Exactly. Like I'm Greek. We're really big on family, and OCD prevented me from spending time with my family. So Karen was like, I remember our conversation. She's like, I'm going to get you reconnected with your family. Like that was like one of the first sessions. Like that was our powwow. I'm going to connect you with your family. And so exposures for me were never sitting there and like, you know, writing out like, I'm killing my family over and over again. It was really just about like, here's what you're doing because of the OCD. Here's where you want to get to. Let's work on making mental and physical changes to get there. A lot of kind of that acceptance and stuff. So I would say ERP, it's just, that's why I always get defensive of ERP, because when people describe it the way that they sometimes describe it, I'm like, I didn't do that. And I didn't get treatment last week. Years ago, that wasn't even the treatment. It might've been that many years ago, but not then.
What about for you, Allegra?
Yeah, I would say like trust in yourself, freedom from the grips of OCD, having clarity, having certainty, like me knowing that I'm not a pedophile. That doesn't mean that I don't have lapses. Like, again, I said last time, like every 6 months or so, I have like a little flare up. And I want to address Erica's comment about like having PTSD and comorbid conditions, because like that's where I'm at. I'm actually doing EMDR right now for like CPTSD. And that I think sometimes contributes to like the lapses in OCD that I get every 6 months. And so it isn't as straightforward for people. If you have trauma from growing up, if you have like PTSD, if you have any other kind of comorbid condition, treatment is going to look a little bit different. Like you are going to have to do that. And that might help with OCD, that might help with eating disorders, etc. So for me, like I feel so much freer from OCD, and I'm working on like trauma that might lead me to still like get stuck every now and again, and the trauma from living with OCD. Like I literally had a session right before this. That's why I was like a little bit late. And like we processed trauma from the onset of my OCD, because OCD can be traumatic. So I just want to add that component too, that like treatment totally looks different if you have comorbid conditions, and like none of our roads were straightforward or like perfectly linear. I think all of us can say now that like we still work on things occasionally, but like we are at a place of like freedom.
And are you willing to share what specific interventions helped get you there?
So like I said, cognitive therapy and mindfulness, it was metacognitive therapy and then mindfulness mindfulness were like the two most important things for me. I was already getting a lot of exposure, just like, I mean, my brain would make a sexual thought about like anyone. So like life was an exposure for me. In my own treatment, I didn't find the like exposure to like pictures of kids as helpful. Like I have to be perfectly honest that like exposure didn't really help me in that way. But other exposures like writing down words, writing down sentences, reading them out loud, that was really helpful for me. And then as I have been like learning about newer stuff like ICBT, I'm also like applying that on myself right now. And that's been really interesting for me. So like I'm definitely like a mindfulness, cognitive response prevention sprinkled with like life and is an exposure girly. Like everything basically.
I love it. I love it.
Yeah. If I could add really quick too, like as you were talking, like or answering your question, Liz, like that was like what I was answering was like the base of treatment. But like Allegra was saying, is like as I got out of treatment and kind of got back into life, there was other things as I was studying to become a therapist that really helped. But one thing that I always talk to my clients about, I don't know if it's taboo in our field, but I'm very honest about it. Like once I was done with treatment, I had a lot of childhood trauma and I never resolved it. And I think the OCD, the BDD was always like so loud. I never got to really deal with just like the way that my childhood was traumatic. And I remember meeting with a general therapist after treatment because it wasn't really OCD anymore. And I'm like, hey, I got better from OCD and BDD, but I'm still miserable. And we talked and she's like, you are so used to like your effed up childhood that you just thought that was normal for you. She's like, this is trauma, right? So we worked on, that for, I would say I was with her for about 2 years after treatment. And that really helped freed up a lot of that. And then, I was dealing with sobriety, so I went to treatment for that. But then after, when I became a therapist, I talked about it last time, like Rich Gallagher's work with disgust really helped me with my disgust stuff. I didn't know it was metacognitive until I watched something by Reed Wilson, but like
hilarious.
A lot of the things that like came up, I was watching something with Reed Wilson and I was like, oh my God, that's a lot of the stuff that helped me. Like one of the things he said is like OCD always attacks the opposite of who you are. And it kind of made sense for my harm OCD. I'm like, I'm most defensive. The people I'm most defensive about is where my harm thoughts went. So that makes sense to me now. So a lot of Kim Quinlan's work really helped. I got her book originally to like help my clients, but there was stuff in there that I'm like, wow, my inner dialogue is so negative, the self-compassion piece. So I think there's so many good things out there, and as the field continues to expand, I'm sure other things will continue to influence me. But there's so many things out there that were positive.
And so like I'm smiling because I'm just like, wow, like a lot of stuff is what helped y'all. Right. And it feels like, ERP was at the core in getting back to living your life and not letting OCD and anxiety make decisions, whether that looked like specific intentional exposures or just life that became exposures in different ways, right? Which is like more important. I'd much rather you go get exposures in real life than look at pictures of kids, right? But I also love the importance that we think about is that ERP should not be standardized. ERP should not go against your values. Jeff Szymanski talks about this a lot. And when Jeff and I used to talk about ERP, one of the things we would talk about is like, it bothers us so much when clinicians will say like, I have a client with these fears and these fears. What exposure should they do?
No,
I don't know. Like ask your client, like, how could any of us know? Because guess what? It shouldn't be exposures that we think make sense or that it's exposures that bring them back to the life they want to be living. Right. And so don't think of ERP as this like, you just have to do these horrible things and you just have to be willing to accept this uncertainty. No, like ERP can actually be values and life that you're just doing and you're learning how to do it without OCD and anxiety. And eventually the goal of even ERP is that you get clarity, because when you go through the treatment and you're able to feel those feelings, live through it, not suppress it, not engage with it and move through it, you're able to see with certainty, that was my OCD. Like, I know that's not me. And I don't want anyone to ever think that OCD treatment should mean you have to be unsure forever, or that OCD treatment means you're never going to know. The last piece is I would love for us to do a part 3 with Lauren Wadsworth, and for us to talk about the evolution of values-based ERP, and for us to talk about social justice-based ERP and how things have shifted. And that's what I was alluding to earlier. I didn't get to it, but like some of the exposures I did for treatment early on 20 plus years ago, they were still useful, but they are not exposures I would ever do with a patient now. And so us also understanding that that's also just a good way for us to remember that treatment should evolve.
Absolutely.
Treatment should shift. And if you are ever working with a clinician who's not willing to learn, who, you know, I've had people be like, well, I don't want to just write this horrible uncertainty script for my client. And I'm like, I don't even remember the last time I used an uncertainty script with a client. Cause like it's not black and white. It's not like if you're doing ERP, you have to be doing these things. And if you're not doing ERP, you can't be doing these things. It's like, no, we all should be doing what our clients need and what's going to help them get to the life they want to live versus the life OCD and anxiety wants to live.
Can I add one tiny thing?
Please.
I feel like so important about like ERP too. I love that, like when you were talking about like people think it's like this torture chamber and how it's like, you know, what are exposures for relationship obsessions? Well, that depends on the client. I can't answer that, but like it's okay if treatment feels uncomfortable sometimes. I think there's this idea that if it feels uncomfortable, it's traumatizing. Well, when I was living with an eating disorder, like no matter how much cognitive work I did, like eating food was fucking uncomfortable for me. It didn't mean that I was doing something wrong or that I was traumatizing myself. I had a phobic reaction to food. And I see that a lot of the times for people with OCD where you've like been triggered so long by something that you almost have this phobic reaction to like children or whatever. And it doesn't mean that you're like traumatizing yourself by having to relearn and show your body, wait, this isn't dangerous. This fucking avocado is not going to kill me, or, you know, this McDonald's Coke or whatever it might be. So like, I like that piece too of like, just because it feels a bit uncomfortable sometimes does not mean that we are traumatizing clients. Like, I think in any treatment modality, there's going to be a bit of discomfort because you're fucking living with OCD or I'm sorry, I'm like swearing a lot, or you're living with an eating disorder. So we can never promise treatment that like doesn't ever feel uncomfortable. And it doesn't mean you're wronging your clients. Like eating
growth
saved my life.
Doesn't come from comfort.
Right.
In life. Like I do therapy every week. I'm not doing OCD work anymore. I don't need to. Now I'm doing like family systems and like deep rooted stuff. And it is uncomfortable as shit. Like I hate it. Like, I don't want to talk about it. And they're like, you need to have this conversation. I'm like, I don't want to have it. I refuse to, you know, but guess what? Like uncomfortability, like you should be uncomfortable in therapy but in different ways. Right. But that's where growth comes from. Yeah.
When I went back to therapy and really deal with like, shout out to her name was Judith Clark. But shout out to Judith Clark. Like when I went back to therapy to deal with this when I did, you know, dealt with my childhood trauma and things like that was uncomfortable too. But like you're saying, growth is uncomfortable. And I think, you know, you were speaking a little bit about ICBT, Allegra. I know for me, there's Brittany Goff had done some graphics about like your vulnerable self theme and like the real self. And I remember I did that for my group and they found it really powerful. And then I think it's, God, I can't think of her name right now. Mandrick Petrick Gardner. I always butcher names, but she's done some. Yeah, she's done some graphics about like trusting your five senses and your common sense. And I did a presentation to my clients on that. And I wanted to go back to what you're saying, Allegra. I think, you know, we pick things that can like work for clients and we can expand our learning and stuff like that. And I think that's super important. And growth is uncomfortable. Learning new concepts is uncomfortable. But ultimately, what I always tell clients is that discomfort should come with a gift. And if you're doing therapy and you're just feeling miserable every week and after week, that's not good treatment. Your treatment should be maybe discomfort as you expand your comfort zone, but it should come with a gift. It should come with, I'm gaining something. I'm reconnecting with my family. I'm reconnecting with things that I care about. So I just want to put that caveat, like growth does come with pain, but when you look back, you're like, man, starting that business was incredible. Starting a family was incredible. Like getting back into movement or quitting smoking was incredible, but it was bumpy.
Mic drop.
We're all like done. Yeah. So, oh my God. So we need a part 3 to 10. So this is part 2 of 10. Thank y'all for attending. Allegra, it is so amazing to have you. And I love being able to just connect together with shared experiences, expectations, but I love that we just come to the table our vulnerable selves. And I'm just so grateful because I know so many people, it sounds like everyone has just wants part 3. So yes, Amy, part 3 for sure. But also everyone just really feels like this is so useful. And yeah, we love you all. So thanks for having us. See you guys soon.
And I want to thank Amy real quick. Amy Ellickson, I want to thank her. She is so incredible in our comments. She always supports people, and then she always shares our lives all across Facebook. So Amy, your work is not missed. You are really help spreading the word. Your advocacy is incredible. So thank you for joining us each time. But bye, everyone. We really, really enjoyed you. Thank you for coming out. This was your live stream. I really hope you learned something, and thanks for supporting us.